presented by Nathan Lowe, affiliated with the Department of Pathology at New York University School of Medicine and the Department of Bioengineering at Rice University in Houston.
Well, thank you very much for that introduction. Today my talk is going to be a bit more basic science, and it's surrounding a novel approach to an HIV vaccine. So everyone here understands the great disease burden of HIV. With 34 million people currently infected and an annual mortality rate of 1.7 million, the severity of this disease is tremendous. For some perspective, for a little more unique perspective, I'm a big fan of the World Mapper, as shown here. And basically what it does is it's a map with the area normalized to a certain factor. In this case, it's HIV prevalence. So you see Africa, specifically sub-Saharan Africa, completely dwarf other continents and developed regions, really showing where this disease burden lies. So current treatment methods, antiretroviral therapy, have done wonders in improving mortality and morbidity in respect to HIV. However, this method is relatively unsustainable. The National Institutes of Health cites that for every one person that begins or is on ARV treatment, 2 more remain infected and untreated. So it's nice to take a step back and think about other solutions. And vaccines provide an ideal solution in that rather than a reactionary treatment, it's preventive. It has the potential to be extremely cost effective, as well as being produced and implemented on a global scale. So much research has gone into the development of an HIV vaccine. However, a large reason why we've been unsuccessful so far is the HIV virus's ability to continually mutate and produce many different strains. So in creation of a vaccine, it's hard to target a conserved region or epitope across the many different strains of HIV. However, interestingly enough, in a minority of cases of those infected with HIV, some patients are able to produce antibodies that can essentially neutralize the HIV virus and stop the progression of the infection. And these are called broad neutralizing antibodies. And 2 famous examples of this is the PG9 and the CHO1 antibody. And these have been isolated and produced in their monoclonal form, and this is going to be the focus of this study. So in the development of this vaccine, we used a novel approach called the immune complex, which is essentially using, in this case, an HIV envelope protein. And rather than presenting that on its own, we supplement it through complexing it with an antibody. So we put the protein and the antibody together, and it forms a complex. And the idea is that through this formation of a complex, you can augment the conformation to better expose a certain epitope or region. So in my nice rudimentary drawing here, you can see that our epitope of interest, the orange triangle, is not exposed initially, but through complex, you can change the conformation to expose this epitope. So the goal of this study was to induce these PG9 and CHO1 broad neutralizing antibodies through the immune complex approach. And the idea is that if we can increase exposure and increase its antigenicity, then we can increase the chances of generating in vivo these antibodies. So the way we went about this is we formed these complexes, and we used an ELISA and probed with our isolated antibodies, the PG9 and the CHO1. And the idea is that if we could achieve and show increased binding with a complex compared to our control, then we've better exposed this epitope. So as you can see here, just a rough schematic, the 2 epitopes of interest are around the V1, V2, and V3 region of the GP120, which is the HIV envelope protein. And the last thing is that we used an A244 protein, and the name's not important. What's important is that it provides a good baseline exposure of these epitopes, and it's actually quite unique in its binding patterns. So the way we went about this study is we first started off with 34 antibodies, and we first assessed the ability of these antibodies to form complexes. So essentially, these antibodies must bind to our HIV protein, otherwise they can't form an actual complex. So we found 16 antibodies that were able to do that. They're displayed in this table here, as well as their respective targeting region. And we found 16 of these. And once we had these 16 viable complexes, we then tested their ability to better expose certain regions, the PG9 and the CHO1. We found 3 vaccine candidates that significantly enhanced this exposure. And these are the antibodies that accomplished that. Notice they're all targeted against the V2 region. So this is a schematic or a graph of these vaccines evaluated at the PG9 site. So our 2158 vaccine in red is shown to have a threefold increase in exposure at the PG9 site compared to the purple control. And for some perspective, about a 50% increase in exposure is considered significant, and this is about a 300% increase in exposure at this site. What's interesting is another vaccine that we found to be extremely effective, the 697 shown in orange, actually has a slight reduction at this site. So this is assessing one of the two sites we're trying to expose, the PG9. But when we look and we probe with our other antibody, the CH01, we get the complete opposite effect. So now the 697 shown in orange, which previously showed a reduction in one site, now shows a great increase, and the same with the 2158 vaccine. So what we have is we have a give and take situation. These vaccines are able to greatly increase exposure at one site, but show a modest decline in exposure in another site. Our third vaccine is a bit of a compromise in that it shows increase in exposure at both of these sites, as shown in green compared to the control once again in purple, but not nearly as pronounced as the two vaccines that we just talked about. So in 2009, the most successful HIV vaccine trial to date was completed. It achieved about a 30% protective effect and used this A244 protein, which is another reason why we chose it. And what's interesting is in this study, they found that a lot of the patients and some of the protective effects were due to the production of V2 antibodies. But if you remember earlier, what we used to complex with these vaccines is a V2 specific antibody, which kind of links in with a fundamental concept in the immune complex approach, in that if you're complexing an antibody on the protein, you're blocking a site. And so you're blocking a potential site for an immune response, but at the same time, the goal is to better improve another site and achieve a net gain. And hopefully these graphs have demonstrated that in vitro we've accomplished that. So right now we're continuing to map in vitro to make sure that we haven't blocked other sites. And soon we'll move into a mouse model by immunizing mice with these three vaccines. And then eventually isolating the blood and the serum to see if the PG9 or the CH01 or other relevant neutralizing antibodies were produced, and then testing their neutralizing breadth and potency. So in summary, my project has dealt with developing 3 viable vaccines through the immune complex approach, and they've induced a 2 to 3-fold increase in one very important epitope, but also show a modest decline in exposure at a different epitope. And this research would be applied to a mouse model in order to translate our in vitro model into assessing in vivo efficacy. And we hope that this project can induce the production of broad neutralizing antibodies to mitigate the global burden of HIV. Thank you very much. I'd like to quickly thank Dr. Ahmed and Kim for giving their wonderful introduction talk, as well as the HGHC committee for giving me this opportunity, as well as my PI, Dr. Katarina Hui, and everyone at the New York University School of Medicine. So thank you very much, and I'd be happy to take questions. Yes. Okay, yes, so this, specifically the PG9 antibody, was actually isolated from the serum of a patient who achieved protective effects through this mechanism. So obviously it's a very, very small number of individuals, but yes, this is one of the mechanisms. And it's also distinguished into a couple of categories, but relatively speaking, it's about the ability to produce these antibodies that can achieve this protective effect.
Is that it? Okay.
All right, well, thank you very much.
Thank you so much, Nathan.